Hi guys, today we're going to talk about some opioids and we're going to focus on some pharmacologic principles, clinical pharmacology, and some unique aspects of each opioids. And at the end, I'm going to talk about how I personally use opioids in my practice. So, as you know, and seen in the last few weeks, that we use opioids a lot. And we use them in general anesthesiology practice, we use them in critical care, pain management, etc. But to use them safely, you need to understand their pharmacology and not just the basic science, but also the clinical aspects of it to be able to use them safely. So, some basic pharmacology. Now, the opioids we use every day have the same structural backbone for the most part and do the same thing for the most part. The prototypical opioid is morphine, and it is a benzylisoquinoline alkaloid. Try to say that 3 times. Basically, the synthetic opioids are molecules derived from morphine by a simple modification of the structure. And an example of that is codeine, which is a 3-methyl derivative of morphine. The same way, hydromorphone, hydrocodone, and oxycodone are also made by simple modification of the morphine structure. When you do more complex alteration of the structure, you get a mixed agonist antagonist like nalbuphine or complete antagonist like naloxone. Now, fentanyl series of opioids are chemically related to meperidine, not morphine. Meperidine is the first completely synthetic opioid and is the prototypical clinical phenylpiperidine, and that's because of the ring structure of the meperidine, the phenylpiperidine, that gives it its name. Now, other commonly used fentanyl conjugares are like sufentanil, which is more of a complex version of the same phenylpiperidine structure, as you can see in the figure. Now, generally speaking, opioids are highly soluble weak bases that are highly protein bound and have a large ionized fraction at physiologic pH. I'm talking about the opioids we use, the IV version, IV opioids. And this is a very big generalization. And when it comes to the large ionized fraction, you got to think about the Henderson-Hasselbalch equation and the role of pKa. Opioid physiochemical properties determine what they do clinically. For example, a relatively unbound, unionized molecule like remifentanil, have a shorter latency to peak effect after you give a bolus. So, what does that mean? It just means that it has a quicker onset because more of the drug is available and can travel to the site of action. So, let's move to the mechanism. When opioids bind to the opioid receptor, we get an effect. The opioid receptors are, for the most part, G protein coupled receptors. And when the ligand, the opioid, binds to the receptor, we get activation of the G protein coupled receptors, which in this case leads to ultimately hyperpolarization of the cell, so less neuronal excitability. So as you can see here, opioid binds to the receptor, G protein gets activated, and when it gets activated, it activates the potassium channels that bring potassium inside the cell, so cell gets hyperpolarized. It can inhibit the adenylate cyclase, so less signaling. It can activate the MAP kinase, and that affects the gene expression and phospholipase A2 pathway, and can inhibit the voltage gated potassium channel, so again, inhibit excitation of neuronal cell. Historically, we talk about 3 opioid receptors of mu, kappa, and delta. I personally have an interest in the 4th type of opioid receptor called ORL1, also known as NOP receptor. When you activate this receptor, you actually enhance pain transmission, and the endogenous ligand for this receptor is called nociceptin, causes pain. Opioid receptors are everywhere. In spinal cord, they inhibit the release of substance P from primary sensory neurons in the dorsal horn, so they prevent transfer of painful sensation to the brain. In brainstem, they modulate nociceptive transmission through the descending inhibitory pathways. They can also change the affective response to pain by acting on the cortex and also modulate the reward structure. Interestingly, in mu-opioid knockout mice, morphine induces analgesia, reward pathway, and withdrawal effect are gone. So again, it helps with the pain when you have no mu receptor, but the reward effect and withdrawal effect are gone. They also don't have any respiratory depression in response to morphine. So again, this is the mechanism they use when they can to determine the effective drug on each receptor, which receptors are important in what. So when it comes to metabolism, the IV opioids that you use every day are transformed and excreted by multiple metabolic pathways. But in general, they're metabolized by hepatic microsomal system and hepatic conjugation and renal excretion, and are important for many of them. Now, whenever somebody asks you about which cytochrome P450 affects metabolism of this drug, you should answer 2 if you don't remember it. 3A4 and 2D6. So cytochrome P450, 3A4 and 2D6. And majority of the opioids we use are actually by 2D6. Now, for some opioids, the specific metabolic pathway involved has very important clinical implication in terms of active metabolite, like morphine and meperidine. They both have active metabolites that are excreted by kidney, so renal failure can become very important. Another example is the ultra short duration of action of remifentanil because of its unique metabolism. For other opioids, genetic variation in the metabolic pathways can change the clinical effect. So an example of this would be codeine in patients that are they have single nucleotide polymorphisms of their CYP2D6 and are a rapid metabolizer or poor metabolizer. So in poor metabolizer, you don't get codeine converted to the active compound, which is morphine, and in ultra rapid metabolizer, you get very high doses of morphine converted very quickly. We'll talk more about these a little bit later. Next, we're going to move on to some clinical pharmacology of opioids. Start with some pharmacokinetics. Now, pharmacokinetic differences are the primary reason you would choose a specific opioid in a specific peri-op situation. Now, the key pharmacokinetic behaviors that you need to know. First, the latency to peak effect affects site concentration after a bolus injection, also known as bolus front-end kinetic, is really the onset after you give a bolus. The time to clinically relevant decay of concentration after bolus injection is also known as bolus back-end kinetic, and this is the duration after a single bolus. Third one is the time to steady state concentration after starting a continuous infusion, also known as an infusion front-end kinetic, is really the onset after starting an infusion. And finally, the time to clinically relevant decay in concentration after stopping a continuous infusion, also known as the infusion back-end kinetic, is really how long an infusion takes to cease having an effect after you stop it. This graph shows what happens to plasma concentration when you give a bolus. As you can see, we give a single bolus, then the drug travels through the veins to the heart, lungs, back to the heart, and then to the effect site, which is really the central nervous system. And here we're really looking at the plasma concentration. Regardless, after the rapid rise, we then have a rapid decline in drug concentration. So take a look at the differences between these drugs and how it relates to the onset. Like you have the morphine here, which is the prototypical slower onset drug compared to remifentanil or even fentanyl. And the initial increase and then decline are definitely different when you compare remifentanil and morphine here. So when you want a quick onset drug, morphine wouldn't be your first choice. Similarly, when your clinical goal is to have a brief duration of opioid effect, remifentanil or even alfentanil, if you can get it, might be preferred. Note that how remifentanil's concentration declines so quickly before fentanyl's peak concentration has even been achieved. Now, the simulation shows why the front-end kinetic of the fentanyl makes it a drug that is so popular for PCA pump 2. I mean, in contrast to morphine, the peak effect of fentanyl bolus comes before a typical PCA lockout period is gone, so dose stacking doesn't become an issue. The latency to peak effect is determined by how fast you get to the equilibrium between plasma and the effect size. Then, if you remember, this is the KE0 parameter. Drugs with a more rapid equilibrium have a higher diffusible fraction. Regardless of that, when you give a very large dose of even a slow onset opioid, you get a rapid onset because we get a supratherapeutic drug level in the effect site, even though the peak concentration comes later. So again, this is not for supratherapeutic dosing, this is for normal dosing. Now this graph shows what happens to plasma concentration when you start an infusion and keep it at the same rate. There's no bolus involved. This is just an infusion like remifentanil. You start at 0.08 mic per kilo per minute. So here we're looking at the time it takes to get to the steady state effect site concentration, also known as the infusion front-end kinetic. As you can see, when you start an infusion, initially you have a rapid increase in concentration, followed by a steady state level. So you can conclude that first, the time required to reach a substantial fraction of the ultimate steady state concentration is very long in the context of our practice. To reach a near steady state more quickly, you have to give a bolus before starting the infusion. And again, as you can see here, remifentanil is probably the only exception to the rule. Also, opioid concentrations will increase for many hours after you start an infusion and you keep it at the same rate. So, remifentanil, again, is the exception to the rule. That's why it's so popular for TIVA. So again, to illustrate the point, remifentanil, you start the infusion within 5-10 minutes, you're at the steady state level. Contrast to fentanyl, takes about 100-150 minutes, 200 minutes to get to the same level, to the steady state level. Fentanyl keeps more than 600, morphine more than 600, and keeps going. So this is, again, what guides you in terms of choosing infusion based on the duration of surgery. Now, this graph shows what happens when you stop an infusion to the plasma concentration of the drug. The time to offset of effect after stopping a steady state infusion is really the context sensitive half-time. And this context sensitive half-time is defined as the time that's needed to achieve a 50% decrease in the concentration after you stop your continuous steady state infusion. So again, this is infusion back-end kinetic, and the big take-home messages from this graph are, first of all, for most drugs, the context-sensitive half-time changes with time. So for brief infusions, the predicted back-end kinetic for the various drugs don't really differ that much. Again, remifentanil is the infusion here. As the infusion goes on longer and longer, the context-sensitive half-time begins to differentiate. So for procedures longer than an hour and a half, for example, you have to think before choosing an opioid infusion. And I say an hour and a half based on this parameter. So if you're doing a fentanyl infusion, 100 minutes, hour and a half, I think that's reasonable time to use fentanyl infusion for shorter procedure. But after that, 2-3 hour surgery, I wouldn't want to use fentanyl. And if you are, then you have to modify your infusion rate. You shouldn't keep it at the same level. The second point is, depending on how long you want the opioid effect to last, you choose either shorter acting or longer acting opioid. So here I'm talking about remifentanil here in the green versus sufentanil in purple. So again, the concentration drops quickly, but you have higher level of sufentanil at the end of a longer procedure compared to remifentanil. You can use morphine or even dilaudid infusion for the same purpose. Now, to apply opioid pharmacokinetic concepts to your clinical practice, we need to understand some fundamental principles. First, a table of pharmacokinetic parameters has limited clinical value, and we really need to use computer simulation to be accurate. So again, looking at the table, seeing that morphine is not highly protein bound, it's not very um, lipid soluble compared to fentanyl, it's helpful, but to be accurate, you really need to use the simulations. Second point is that the pharmacokinetic implications of giving opioids in bolus versus infusion are very different. So I use the same concept when using propofol infusion versus bolus up in GI suite. And if we're up there together and you use bolus of propofol instead of using an infusion, we will have a conversation about it. And thirdly, pharmacokinetic information must be integrated with knowledge about the concentration effect relationship and drug interactions to be really clinically useful. Here I'm talking about the pharmacodynamic. Next, we're going to move on to some pharmacokinetic aspects of use of opioids. Start by talking about the effect on CNS. High doses of opioids can cause deep sedation or hypnosis, but always remember that opioids don't reliably produce amnesia, so they're not the perfect anesthetic. Opioids reduce the MAC of inhalation anesthetics. Seizure can result from neuroexcitatory effects of normeperidine, which is a metabolite of meperidine, and normeperidine-induced seizures are more likely to occur in patients who have been receiving meperidine chronically, or people who get a large bolus of meperidine over a short period of time, or have renal dysfunction with decreased ability to eliminate this metabolite. So if you give meperidine or demerol in your spinal, this should not be an effect. Opioids can reduce cerebral metabolic oxygen requirements, cerebral blood flow, and intracranial pressure as long as you control the ventilation. Opioids cause meiosis by stimulating the Edinger-Westphal nucleus of the oculomotor nerve. In patients where ventilation is not controlled, opioid-induced respiratory depression, thereby hypoxemia, that results in pupillary dilation and an increase in intracranial pressure because of the hypercarbia. And opioids stimulate the chemoreceptor trigger zone located in the area posterema of the brainstem, which can result in post-op nausea, vomiting, or any nausea and vomiting. Now, when you give opioids, you decrease minute ventilation, and you decrease it by decreasing respiratory rate, not tidal volume. In fact, tidal volume may actually go up most commonly. Opioids have a direct effect on the respiratory centers in the medulla, producing a dose-dependent depression of the ventilatory response to carbon dioxide. You will get a decrease in slope and rightward shift of the CO2 response curve, as you can see here. So a normal person, you have this kind of V, U-shaped thing for the CO2 response and minute ventilation. When you give opioids, you lose the curve and it's right shifted. The apnea threshold is the highest arterial carbon dioxide concentration without ventilatory effect, and opioid increase it. So if you normally increase your CO2, your minute ventilation at arterial CO2 of 40, you give opioids, this normal response is going to be right shifted to right shifted. So you start increasing minute ventilation at 45, for example. Opioids also blunt the increase in ventilation in response to hypoxemia. So that's why when you give opioids to patients, you gotta put them on oxygen, because then they may not be able to increase their arterial oxygenation depending on how much you gave. Now, don't forget that morphine and meperidine can cause histamine-induced bronchospasm. And bronchospasm is bad. Opioids can produce generalized skeletal muscle rigidity, and this is more pronounced with the more potent opioids like fentanyl, sufentanil, and remifentanil. Loss of chest wall compliance and contraction of laryngeal and pharyngeal muscles can be severe to the point that it can get really hard ventilating these patients. In fact, I saw one of these when we were inadvertently overdosing the patient on remifentanil, so we could have ventilated the patient. And the mechanism of this muscle rigidity is thought to be mediated by receptors at the supraspinal level by increasing dopamine synthesis and by inhibiting the GABA activity. Now, luckily, this muscle rigidity can be prevented by giving the opioid slowly or by neuromuscular blocking agents and controlling ventilation. That's what we did. We gave a dose of rock, and everything was good. Post-op shivering can be treated with meperidine too, or really any opioids can treat post-op shivering. But for meperidine, we really need small doses of 12.5 to 25 milligram to take care of it. And interestingly, clonidine is another agent that can be used to treat post-op shivering. At clinically relevant doses, opioids don't cause significant myocardial depression, but they cause a dose-dependent bradycardia, resulting in decreased cardiac output. So whenever you see on your boards, are opioids cardiac depressant? The answer is no. Now, one exception is meperidine, which may cause tachycardia because of the structural similarity to atropine. Meperidine may also cause a decrease in myocardial contractility because it has a negative inotropic effect. But most opioids exert their cardiovascular effect both by sympatholysis via vasomotor centers in the medulla and by increased parasympathetic tone via vagal pathways. Don't forget the prolongation of the QT interval that can be seen with meperidine and methadone. Opioids increase non-peristaltic smooth muscle tone in the small and large bowel via vagal and peripheral mechanism. But just because we have more muscle activity doesn't mean that we have actual motion of matter through the GI tract. This is an ineffective, non-propulsive activity that leads to overall increase in bowel transit time and can result in ileus. They can also cause spasm of sphincter of Oddi, which is relieved by giving glucagon. Sometimes we do give glucagon in ERCP, actually more often than not. Opioids may decrease the stress response to pain and surgery by acting on the hypothalamus. The inhibition of gonadotropin releasing hormone and corticotropin releasing factor results in decreased release of endogenous cortisol, so less stress response. Now, true allergic reaction to opioid is very rare, but they can cause a non-IgE mediated release of histamine from mast cells, decreasing the systemic vascular resistance that results in decreasing blood pressure and tachycardia. You will see this respond with large doses of meperidine and morphine. I saw this once a little while ago, well, a few years ago now, when I gave 10 milligram of morphine bolus in a cardiac induction case. That was fun. It's worth noting that due to its many associated toxicities, meperidine is not really used very often, except if you work with one of our colleagues. But it's still used for management of post-op shivering, and it still remains the most commonly used agent to treat shivering post-operatively. And again, 12.5 to 25 milligrams is all you need. Opioids, which are intended to treat pain, may actually make patients more sensitive to pain and may worsen pre-existing pain states. Now, initially, opioids provide clear analgesic effect, but then can become associated with hyperalgesic response. Opioid-induced hyperalgesia was initially discovered in patients taking chronic opioids, but can definitely be seen in a short case too. Like after hour-and-a-half craniotomy with remifentanil propofol combo, you can definitely see hyperalgesic patients. Most of the time, we don't recognize it, but you can see it. When you give ketamine before opioids, and again, before giving opioids, if you give ketamine, this hyperalgesic response is significantly blunted. Now, other medications that also reduce hyperalgesia from opioids are clonidine and by extension dexmedetomidine, gabapentinoids, IV acetaminophen, and also other NMDA antagonists like magnesium. IV lidocaine is not one of them. Dependence and tolerance are two significant problems with long-term opioid use. Now, dependence is the presence of withdrawal symptom if a drug is withheld and can be either physical or psychological. Psychological dependence refers to craving for a drug and is synonymous with addiction. Tolerance is the need to increase the dose of an opioid over time to maintain the same analgesic effect. This reflects the desensitization of the anti-nociceptive pathways to opiates and upregulation of opioid binding receptors. Now, keep in mind this is different from opioid-induced hyperalgesia. With opioid-induced hyperalgesia, you reduce the dose, and the patient who's screaming in pain will have less pain. With tolerance, you have to increase the dose to treat the pain. Now, this figure is just a summary of the most significant locations where opioids have an effect and you need to be aware of in your practice. Drug interaction can be based on two mechanisms. It can be based on pharmacokinetic, like where one drug influences the concentration of another drug, or pharmacodynamic, where one drug influences the effect of the other drug without affecting the concentration. Now, in our practice, although unintended pharmacokinetic interaction occurs often, pharmacodynamic interaction happen all the time, and they can actually be useful. The most common pharmacokinetic interaction in opioid pharmacology is when IV opioids are combined with propofol. You've seen this. Propofol decreases your preload because of venodilation and maybe a little SVR. This results in opioid concentrations that are higher than when you give opioids without giving propofol. The most important pharmacodynamic interaction here is when you combine the opioids with other sedatives. When you combine opioids with volatile anesthetics, they reduce the MAC of the inhalation anesthetics. And this happens because opioids synergistically reduce the MAC, and the MAC reduction is substantial and can be as much as 75% or more depending on how much opioid you get. Most of the MAC reduction occurs at pretty moderate opioid level, and even modest opioid doses substantially reduce the MAC, so even 1 mic per kilo of fentanyl. And the MAC reduction is not complete. That is, opioids are never complete anesthetics, and the addition of opioids can completely eliminate the need of your inhalation anesthetic. And lastly, there are an infinite number of hypnotic opioid combinations that you can use to achieve the same MAC. So this means it can be inhalation anesthetic combined with opioids. It can be propofol, ketamine, even etomidate, or any other sedatives you can think of. Now let's talk about some special population. Now, even though liver is the metabolic organ that's responsible for biotransformation of most of the opioids, liver failure is usually not severe enough to have a major impact on your opioid pharmacokinetics. Of course, when you do a liver transplant, the anhepatic phase is an exception to this general rule. And when you keep giving opioids at the same rate, the concentration of opioid, except remifentanil, increases when the patient has no liver. Even after partial liver resection, an increase in the ratio of morphine metabolites to morphine does happen, which shows a decrease in the rate of metabolism. But this is for the most part not clinically significant, because remifentanil's metabolism is completely unrelated to liver clearance mechanisms. Its disposition is really not affected during liver transplantation either, so it's a great drug for that case. Pharmacodynamic considerations can be important for opioid therapy in patients with liver disease. So patients with ongoing hepatic encephalopathy, so severe liver disease patients, are especially vulnerable to sedative effects of opioids. So be really, really careful with opioids in severe hepatic disease, and essentially if you titrate them to effect very slowly, you're going to be the safest. For fentanyl congeners, the clinical importance of kidney failure is not really that important unless you're talking about infusions for a long time. Remifentanil's metabolism is not affected by kidney disease. Renal failure has some major consequences for using morphine and meperidine, though. Morphine is primarily metabolized by conjugation in the liver to water-soluble glucuronide, specifically morphine 3 glucuronide and morphine 6 glucuronide, M3G and M6G. The M3G and M6G are excreted by the kidneys. And the kidney also plays some important role in conjugation of morphine, and it may actually be responsible for conjugation to M3G and M6G for about 50% of the metabolism. Now, M3G is inactive, so don't have to think about it too much. But M6G is an analgesic with similar potency to morphine itself. And very high levels of M6G and life-threatening respiratory depression can occur in patients with renal failure. So don't use morphine in patients with severe renal disease. The clinical pharmacology of meperidine is also significantly affected by renal failure. Now, as you remember, normeperidine is the main metabolite of meperidine, and it has analgesic as well as excitatory CNS effect that can range from anywhere from anxiety to myoclonus to even frank seizures. Because normeperidine is subject to renal excretion, CNS toxicity secondary to its accumulation is especially a concern in renal failure patients. So don't use it in renal failure. Now, interestingly, morphine is more potent in women, but with a slower onset of action. Some of these differences may be related to cyclic gonadal hormones and psychological factors, but really we don't know. Just know that it's more potent in women, especially older women, but it kicks in slower than men. Advancing age is clearly an important factor that you have to think about before giving opioids. For example, fentanyl congeners are more potent in the older patients. You've seen this. We have decreases in clearance and central volume of distribution of older patients. But keep in mind, with advanced age, pharmacokinetic changes play a role, but it is really the pharmacodynamic differences that are the primary culprit and the reason you have to reduce your opioid doses in them in patients over 65. For example, I have a patient over 80. My remifenol dose is half of what I would use in patients that are younger. And again, titrate to effect. Opioid pharmacokinetic parameters, especially clearance of the opioid, is more clearly related to lean body mass and not the total body weight. Now, in practical terms, this means that morbidly obese patients do need a larger dosage than the lean patients to achieve the same target concentration. But in the very obese patients, you don't need nearly as much as you would predict if you use their total body weight for dosing. For example, as you can see in the figure here, total body weight based dosing scheme here in orange results in much higher remifenol effect site concentration than dosing calculation based on lean body mass that you can see here in purple. And in contrast, for lean patients, the total body weight and lean body mass dosing schemes result in the same concentration. So for a lean patient, it doesn't matter, but for obese and morbidly obese patient, you should use the lean body mass for dosing. So next, we're going to talk about some unique features of each opioids, the IV opioids, and how I personally use them in my practice as an example. Now, we don't really use codeine intraoperatively, but it has special importance because of the interesting pharmacogenomic differences associated with it. Codeine is actually a prodrug. Morphine is the active compound. Codeine is metabolized by O-demethylation into morphine by the liver microsomal isoform, the cytochrome P450, CYP2D6. And again, I told you, remember CYP2D6 and 3A4 for multiple choice questions. About 10% of our patient population lacks the CYP2D6 because of deletion, frame shift, or splice mutation, or if the patient's taking the inhibitor of the cytochrome, like quinidine. So if we give them codeine, there would there wouldn't be any significant response from it. But if you gave the same patient morphine, they would have a normal response to it. Now, this should make you think about oxycodone because it's also primarily metabolized by CYP2D6. Morphine is the prototype opioid, so we compare other opioids to it. So when you want to look at potency tables or apps nowadays, everything is compared to morphine. There's no evidence that any synthetic opioid is more effective in pain control than the good old-fashioned morphine. But it can cause histamine release and the resulting hypotension, so we used a lot of their fentanyl intraoperatively nowadays. Morphine has a slow onset time. Its pKa makes it almost completely ionized at physiologic pH. So, highly ionized and low lipid solubility accounts for morphine's prolonged latency to peak effect, so slower onset. Morphine penetrates the CNS slowly, and this feature is both good and has some disadvantages associated with it. So, the prolonged latency to peak effect, the prolonged onset, means that morphine is perhaps less likely to cause acute respiratory depression after given a bolus compared to like a more rapid onset like fentanyl. On the other hand, the slow onset time means that we are probably more likely to stack multiple doses because the patient's still hurting 5-10 minutes after you've given a dose. Morphine's active metabolite M6G, morphine 6-glucuronide, as you remember, has important clinical implications. Now, normally about 10% of morphine is metabolized to M6G, but the M6G continues to contribute to analgesia after the morphine concentrations drops. This holds true even in patients with normal renal function, particularly when they use morphine for long term. Remember that morphine has high hepatic extraction ratio, so the bioavailability of orally administered morphine is significantly lower than that of the IV injection. But the hepatic first pass effect on PO morphine results in much higher M6G levels. And probably M6G may be the primary active analgesic when people take oral morphine. Now, don't forget the M6G's accumulation and potential toxicity in dialysis patients. Now, how do I use morphine? I don't use it very much, but the only times I use it are for spinal in enhanced recovery pathway, usually 0.15 milligram or 0.15 cc of the 1 milligram per ml solution. Now, I occasionally use 1 to 2 milligram IV every 3 minutes intraoperatively as part of a balanced anesthesia care in only surgeries that are very painful, like open belly surgeries. But other than that, I don't really use it very much. Now, fentanyl may be the most important opioid we use in our practice. It's highly lipophilic, has short onset and short duration. Its context-sensitive half-time is not good enough for infusion unless for a short case. One unique thing about fentanyl is that it can be delivered in multiple ways. In addition to IV, you can give it transdermal, transmucosal, transnasal, transpulmonary, etc. Now, oral transmucosal delivery of fentanyl, the famous fentanyl lollipop, results in a faster onset and higher peak levels than when you swallow the same dose, as you can imagine. And avoidance of the first pass effect results in much higher bioavailability. And as you can imagine, the fentanyl patch has a very slow onset, but when you take it off, it takes several hours to stop working because the skin and subcutaneous tissue act as like a depot. Now, how do I use fentanyl? I go back and forth in terms of using it often, but generally speaking, I almost always use it in low doses, 20 to 25 mic combined with local anesthetic in my spinals, and also 100 mic combined with local anesthetic for C-section epidural. So if I'm dosing up to C-section for epidural, I sometimes use it 50 to 100 mics before induction so that I can get sedation, euphoria, and help decrease the sympathetic response to intubation. Usually you need about 3 to 5 mic per kilo to blunt the sympathetic response completely, but I almost never use that much. Sometimes I use low doses 25 to 50 mic boluses intraoperatively to blunt the sympathetic response to surgical stimulation. Sometimes low dose before emergence to make the patient cough less or smoother emergence. And for cataract surgery in particular, I use usually 25 mic, sometimes 50 mic combined with midazolam for light sedation. And postoperatively, low doses every 5 minutes for pain. Now, something I really like to use is for pediatric ENT cases. In ear tube replacement, I really like to use 1 mic per kilogram intranasally in those patients, usually when they're done with one ear and ready to move on to the other one. And this significantly results in less emergence delirium. Now, similar to fentanyl, Sufenta is highly lipid soluble and protein bound, but its onset is faster with much better context sensitive halftime, so it can be used for infusion. What separates Sufenta from other opioids is that it is the most potent opioids that we use in clinical practice. So it has a much higher partition coefficient than that of everything else, including buprenorphine. Now, as you probably remember, buprenorphine is very effective in addiction maintenance because it binds to the opioid receptor so tightly that when the patient injects heroin, it can't displace the buprenorphine and get the patient high. But sufentanil can. So if you're giving a patient a buprenorphine, the only opioid that would reliably work for them is Sufenta. Hydromorphone should be your second choice because it has a little lower binding capacity than buprenorphine, and with high enough concentration, you should have some effect from hydromorphone. Now, again, I don't use sufentanil very much because I think remifentanil is better for infusion, but when I use it, it's primarily for TIVA and its low dose is 0.05 to 0.01 mic per kilo per minute range. As infusion patients with buprenorphine who are having painful procedures like laparotomy, so not everyone, but the patients who are still under buprenorphine, which they should not be for painful surgeries. Now, compared to remifentanil, when you do an infusion as part of your TIVA, the analgesia lasts longer, so it is better for painful procedures, not for like tiny little dead cells, and the patients are going to go home. Now, remifentanil is the prototype example of how a specific clinical goal can be achieved by designing a molecule with specialized structure activity, or really structure metabolism relationship. Now, in Remi, we're losing its mu receptor agonist activity with ester hydrolysis, so we get a very short-acting opioid. Compared to other opioids, its context-sensitive half-time is much shorter, in the order of about 5 to 7 minutes. And pharmacodynamically, it exhibits a short latency to peak effect similar to alfentanil, and as you can remember from the figure, and a potency slightly less than that of fentanyl, at least according to the books. In my opinion, it's slightly more potent than fentanyl, but I may be a little biased because of the quicker onset of remifentanil compared to fentanyl, kind of clouding my judgment. Remi is a great choice when you want a rapid recovery, when the anesthetic requirements rapidly change, when opioid titration is unpredictable or difficult, when you're really worried about opioid overdose, or when a high-dose opioid technique is needed, but the patient is not going to be ventilated post-operatively. For example, when you're doing a craniotomy, I usually run my Remi at low doses, and when they're about to do the bone saw to the skull, I give a little bolus before that and then go back to the same dose. Now, when I use remifentanil, it's primarily as part of a TIVA. Usually you go from 0.08 to 0.15 mic per kilo per minute. And whenever you use remifentanil, you got to think about the hyperalgesia, because even after 30 minutes, 60 minutes TIVA with Remi and propofol, if you don't give any other agents to blunt the hyperalgesic response, you can get opioid-induced hyperalgesia. And the medicines that are known to blunt this hyperalgesic response are ketamine, which is the strongest, IV acetaminophen, clonidine, by extension dexmedetomidine, and magnesium as another NMDA antagonist. Now, I use Remy quite often in patients that I want a smooth wake up without coughing, like carotids, and usually I leave the infusion at 0.08 mic per kilo per minute during emergence and don't turn it off till after the patient is extubated. And I really like Remy for awake intubation, especially when I'm not confident about the local anesthetic effect of the airway structures. Like somebody had radiation to head and neck for cancer, and now I gotta do an awake intubation. I just use Remy and I start at 0.08 and titrate the dose up until the patient can tolerate awake intubation. Now, last but not least, hydromorphone is the other drug that we didn't talk too much about because it doesn't have a lot of unique things about it, but we do use it often. And the onset is a little slower compared to fentanyl, but faster than morphine, so 15-minute onset, less protein bound, and less lipid soluble compared to fentanyl, but more than morphine. And also, the duration of action is longer than fentanyl, but shorter than morphine. It has some renally excreted active metabolites, so you got to be careful about it in renal infusion. Its context sensitive half time is better than fentanyl, despite what you would predict if you looked at the pharmacokinetic table. But it's definitely not as good as remifentanil or sufentanil. And when I use hydromorphone, I usually use 0.2 to 0.5 milligram every 30 minutes intraoperatively if I'm using balanced anesthesia care, especially in painful surgery. So I don't use it often, but sometimes in painful surgery I do. And the other time post-op for pain, and usually 0.2 to 0.4 every 5 minutes. I hope you